Good evening, all the aspirants. Today's topic is sodium disorder in ICU, and the speaker that we have here is Dr. Suvadeep Sen. He is an consultant in ICU at Apollo Hospital, Navi Mumbai. And the organizers that we have today are Dr. Akhilesh Chandekar, Dr. Gunadhar Pari, and Dr. Asif Iqbal. Sir, you can take over. Thank you.
Sure. Thank you, Fatma. Thank you for the kind introduction. So, today we'll try and discuss the sodium disorders in the ICU. I hope everybody over here is the DNB aspirants or doing some course in the critical care medicines or practicing in the ICU. Is that okay?
Yes, sir.
Okay, sure. So, in next 1 hour, we'll try and discuss the various sodium disorders in the ICU. We'll try to keep it a more practical based scenario, not very theoretical discussion, and trying to go through the with the some case vignettes and so that it becomes more practical, day to day case oriented, and the amount kind of questions you are supposed to get asked in the in your exam or the kind of clinical scenario that you are often see that in your daily rounds that will try and address in the sodium disorders in this today's discussion session. At any point of time, if you have any doubt, you may interrupt me and try and ask the questions, but preferably you can just put up some questions in the chat box and you can try and discuss those chat questions at the end of the discussion session. Is it okay to everybody? Hope everybody is able to hear me. I do not want to start with the physiology, which is boring to most of the things, because most of the hyponatremia discussion starts with some physiology. Today, I don't want to start with the physiology discussion, except only one physiological aspect of our body is the physiology of antidiuretic hormone, so which is called vasopressins. Because the entire concept of sodium change inside our body is basically is a water regulation problem in the water regulation inside our body, which is predominantly done by the antidiuretic hormone or vasopressins inside the body. So we should know how the ADH works. When does it get stimulated? When does it get suppressed? Because the stimulation and the suppression of the ADs, they play the most crucial role in the change in the sodium balance inside our body. And you must have heard the things that the sodium disorders is basically is a problem of the water regulation problem inside our body. And the water regulation problem that majorly happens because of these stimulations and the suppressions of the antidiuretic hormone that is commonly caused as the vasopressins. And I want you to know only two things. First of all, the ADH gets stimulated only with two mechanisms. Either it's osmoregulatory mechanisms, like whenever the body's osmolarity changes, it increases the ADH gets stimulated, or whenever or second is the baroreceptor mechanism. Whenever the blood pressure changes inside the body, the ADH gets stimulated, and whenever the ADH gets stimulated, what it does is two actions, V1 and V2. V1 is mainly in the blood vessels, is constrict the blood vessels and maintains the blood pressure, and V2 is that it tries to reabsorb a lot of water inside the body and maintains the volume status in the body. This is the only thing that you're supposed to know to understand the entire sodium physiology, because every point of time we come across with a lot of hyponatremia or hypernatremia, we will discuss a lot about the ADH disorders inside our body. Okay. And first we'll start with the hypernatremia. Most of the time we start with the hyponatremia, but today because hyponatremia gets discussed a lot of time and the hypernatremia becomes a neglected entity most of the time, we will start a discussion for the hypernatremia. And hypernatremia means it is a state of relative or actual water deficit. It might not be on sodium overload. It is a state of water deficit. We'll start with a case vignette. Again, very common scenario. Most of the time, a lot of time we come across. Please remember the case vignette whenever you go through, because we will discuss the entire sodium discussions with this case vignette only. A 58-year-old woman with a postoperative ileus is undergoing a nasogastric suctioning, and now she has come with an obtunded state with a diminished skin turgor with a mild orthostatic hypotension. Her sodium was found to be 158 millimole per liter, and the potassium is around 4. Her body weight is 63 kilograms. So she has come with an hypernatremia. Okay, we'll start the discussion. We'll have some theoretical discussion on the hypernatremia. Why discussion about hypernatremia is important in ICU? Because first of all, it is very common in ICU. We see the presence of high sodium a lot inside the ICU, and mostly it is iatrogenic. Most of the time, whatever hypernatremia we see, they are given by the doctors. So we should know it. First of all, we should know it how to prevent it, and second, we should know how to treat it. Why it is mostly iatrogenic? It is mostly iatrogenic because either we tend not to give the amount of the reserved volume, whatever the patient requests. The patients mostly are intubated, ventilated. They do not, even though they are thirsty, they'll not be able to tell you. So it all depends on how much volume you're giving to the patients. In any case that you are giving less volume to the patient will land up in the dehydration, the patient will land up in the hypernatremia. That is the most important thing. So mostly it is iatrogenic in ICU. Second thing is the hypernatremia is not benign. Because if it is not properly addressed, first of all, the patient remains agitated. You end up giving a lot of sedations to the patients, and your sedation requirement goes up. That you end up staying more days on the ventilator. You stand up more days in the ICU, and it's a risk factor of the delirium. So it is not benign, and it has been found to be an independent marker predictor of the mortality as well. Severe hypernatremia. Anybody comes with a severe hypernatremia, they can lead to a death. So it is not benign at all. And third thing is that hypernatremia cannot be corrected automatically. You cannot assume that the patients are having hypernatremia and you're not doing anything and the sodium will get corrected. You have to do sort of intervention or reverse the pathology to correct the hypernatremic state. And most importantly, hypernatremia is a hallmark of low quality amateur ICU care. It has been written again. The term is not written by me. It has been given in it has been written in this paper that I have quoted over there. It's a hallmark of low quality and amateur ICU care. So, your patient is developing hypernatremia because of iatrogenic cause. That means your ICU care is not proper, and especially this sustained hypernatremia. So we should all know that what is hypernatremia, what are the why it develops, and how to prevent it. Coming to the etiology, so again, we should all know that the hypernatremia doesn't happen in somebody who is conscious and whose thirst mechanism is not impaired. Hypernatremia doesn't happen because the body's sense of thirst is extremely robust system. Whenever we are slightly dehydrated, our mechanism gets activated, and then we tend to drink water, and the sodium doesn't rise. Hello? Is there anybody talking anything? Okay. No. So if you're somebody developing hypernatremia, that means that either we're not addressing to the thirst, or the patient is not getting adequate, or somebody is not getting adequate water even in there is a thirst, or patient doesn't have any thirst at all. And usually it is a thirst is an hypothalamic function. So somebody who is alert, conscious but not thirsty, that means that he must be having some hypothalamic dysfunction. So always, whenever somebody is developing hypernatremia, either it is iatrogenic or somebody having some problem in the hypothalamus where the thirst system is not proper. So that is the only etiology where the hypernatremia can happen to a patient. Classically, four different causes that you should know. First is inadequate water intake. That means the patient is not able to drink water. Somebody is extremely dehydrated for a long period of time. Somebody who is very usually it happens. Somebody is where the thirst mechanism is impaired, like somebody is an elderly or infants. Somebody with an increased insensible loss, sweating, burns. Somebody where we fail to provide adequate free water to an intubated patients. The other situations that the hyponatremia can happen. Second mechanism is the GI loss. Either somebody is vomiting, diarrhea, or intestinal fistula. Kidney loss with the free water, either due to the osmotic diabetes or the loop diuretics, or somebody who is developing diabetes insipidus due to lithium, somebody with an alcohol or severe decay or honk, and the primary hyperaldosteronism. So those were the free water loss to the kidney that happens. And where the patient is having, we are giving iatrogenic sodium to the patients, like we're administering a lot of bicarb, hypertonic saline, where we fail to monitor the sodium, where patient is losing hypotonic fluid and you are correcting with balanced salt solution or isotonic fluid, then your sodium will rise. And somebody who has a drowning in the seawater, they can land up in a hypernatremia. So we should know the mechanism of all these things. Again, I'm not going into details because the today's discussion is more practical. But it is important to know the cause. How does it? What is the pathophysiology? What happens in the hyponatremia? Again, I hope everybody has seen this picture. So again, it was there in NEGM. It's a very famous article. Everybody should read this article to be very frank. How does hypernatremia affect pathophysiologically? What happens in the brain? Because whenever there is hypernatremia, the brain becomes shrinked because of the tonicity increases, the brain shrinks. Because the brain shrinks, so we develop a lot of cerebral bleed or some SAH, those kind of things that happens. Now, with time, and brain try to adapt. With accumulation of a lot of low osmolarity osmolytes accumulates inside the brain. So overall, the brain's osmolality that increases. So that is how brain try and adapt with time. Now, why the correction is important at the time of whenever we try and correct and we try and correct rapidly, what happens is the brain is now a little hypoosmolar state. Now you give a lot of free water. What happens? The brain tissue swells. And what happens if the brain tissue swells? It develops edema and then lands up in the problem. So that is why rapid correction is not appropriate in patients with a chronic hypernatremia. So you should correct very gradually. But if you remember this picture, then it becomes very clear that why what is the pathophysiology that happens inside the brain, why the hypernatremia causes mortality inside the what kind of problem it causes in the brain, and why the rapid correction is not right in patients with hypernatremia. Signs and symptoms depends on the mild, moderate, and severe. Depends on the level of the hypernatremia. Anything less than 145 to 150 is a mild hypernatremia. But the patients are mainly they're having dry mouth. They're mainly thirsty. They complain of thirst. And somebody who cannot complain of thirst, who cannot complain, they become restless. So, and you can see the evidence of dehydration in those patients. Somebody who are moderately hypernatremic, that means the sodium is more than 150, between 150 to 160. They are because of this increase of the brain, they become irritable, they develop muscle weakness, vomiting, nausea, and those kinds of things happen. Somebody who is severely hypernatremic, that means the sodium is more than 160, then they'll end up in a severe confusion. Sometimes they develop seizure, and sometimes they develop hemorrhage inside the brain because of this shrinkage of the brain tissue. And somebody whose sodium is more than 170, then they develop irreversible neurological damage because of this uh, tight shrinkage of the brain, and they develop land up in the coma, unresponsiveness, and sometimes they land up in a mortal death. So it's a you try and remember this slide as much as possible, but overall, if you can just go by the sequence how it happens. Now, most important over here is how do we address hypertension? Anybody in the hypernatremia. First step is we need to take a good history because most of the time the etiology of the hypernatremia is it can be derived the from the history itself. You take a proper history and you will be able to understand what is the cause of the hypernatremia. History is also important to understand the severity of the hypernatremia. So somebody only thirsty, that means that the probability is only mild hypernatremia. Or it also tells you that the chronicity of the hypernatremia, whether somebody is hypernatremic for a long standing, more than 48 hours, or somebody is hypernatremic acutely. So what do we take in the history? For the etiological understanding, that we take the try to understand what is the history of whether there is a history of GI loss is there, present somebody is a fever, persistent fever, burn, excessive sweating, they end up losing a lot of hypotonic fluid and then they develop hypernatremia. Elderly patient with a dementia, prolonged bedridden state, they most of the time they come to the ICU with a hypernatremic state, especially whenever their intake goes down. Patient on a ventilator or NIV with an humidifier, they tend to lose a lot of water and then become hypernatremic. Patients with the severe hyperglycemia, then we should use even the sodium, serum sodium, measured sodium is normal. If you correct the sodium with the sugar, then we found that the actual sodium is high, so they are basically hypernatremic. A history of hypertension in young age indicates the presence of the primary hyperaldosteronism. Most of the time, patients with a primary hyperaldosteronism develop has a degree of mild hypernatremia as well. Somebody who is polyuric, they usually suggest the presence of some form of diabetes insipidus or some form of osmotic loop diabetics. So we need to see that the whether somebody who is polyuric and then the sodium is high, then either it is diabetes insipidus or it is because of this use of the lot of use of excessive use of diuretics. Somebody with a prolonged administration of normal saline, hypertonic saline, or bicarbonate, they tend to develop hypernatremia. So we need to see that when the patient has received bicarb a lot in the ICU, so that might be the cause of hypernatremia. We need to take a good drug history like lithium, amphotericin B. They cause nephrogenic diabetes insipidus and then cause diabetes hypernatremia. Patients with a mannitol, excessive diuretics, high dose potassium, sometimes they land up in hypernatremia. And somebody with a history of brain injury or traumatic brain injury or somebody who has undergone a pituitary surgery, if they develop hypernatremia, then it usually indicates central diabetes insipidus. So that is how your history gives clues to most of the etiologies in day-to-day practical cases. Second step is the clinical examination. So we try and assess the volume status. Uh, and so we see that whether the patient is euvolemic and hypovolemic or hypervolemic, because sometimes the clinical management they do differ in the management part. And thirdly, we check the biochemistry. Two important thing is that urine sodium and the urine osmolality. Urine osmolar, first of all, check the urine sodium. Why urine sodium is important? Suppose somebody comes in hypernatremia and urine sodium is less than 20, that means the patient is hypovolemic. So that means that there has to be some extra loss of fluid from the body, and that is a cause, and the patient is hypernatremic because of this dehydration. If the patient is urine sodium is more than 20, it is usually tells either the because of this post renal salt wasting or it's a solute overload that we have given to the patient. That is that the patient is hypernatremic. But more important, the urine sodium is the urine osmolality. Usually, if the urine osmolality is more than 600 in patients with hypernatremia, it suggests the patient again the patient is hypovolemic. Probably the patient so that is the urine is concentrated. Usually, they are associated with the urine sodium less than 20. But if the urine osmolality is less than 300, that means the mostly the etiology is diabetes insipidus, and that is why the patient is hypernatremic. And if the urine osmolality is around 300 to 600, that means that it can be either because of this administration of the diuretics, osmotic or loop diuretics, or it is a post-obstructive diuretics. So that is why the urine osmolality is 300 to 600. At any point of time, urine osmolality is less than 300. That means the patient is diabetes insipidus. Then we should start evaluation of the diabetes insipidus, whether it is nephrogenic and or central diabetes insipidus. And come back to that part. How to correct the hypernatremia? Again, the questions always gets asked. What is the principle? That principle is that we need to correct. We need to administer the free water to the patients. The oral and gastric tube is the safest way to correct. If oral or gastric tube is not feasible, then we need to correct IV. IV either we give D5 dextrose, or we give one-fourth normal saline, one-fourth saline, or one or half strength saline.
Mama. Mama.
Usually, we do not give normal saline to correct the hypernatremia because unless the patient is hypovolemic and patient is dehydrated and the patient is sign of hypoperfusion. If those kind of patient is very hemodynamically unstable but hyponatremic, then we can give some balanced salt solution. But most of the time, we should not give normal saline to correct hypernatremia. And we should maintain a target fall of serum sodium concentration less than 10 millimole per liter per day, because as I've told the if you correct sodium rapidly, it will lead to cerebral edema and then it becomes counterproductive. And most importantly, we need to correct the underlying cause like prevent the gastric fluid loss, control the fever, treatment of the sugar, treatment of the withhold the diuretics, lactulose, hypercalcemia, whatever is whatever is the cause that we need to stop that precipitating cause. So there is the three major arms in treatment of the hyponatremia. How to treat the mild hypothermia? Suppose the hypothermia is mild and the patient is awake but thirsty and able to drink, then we should encourage them to drink. We may not give them free water IV. So you can just tell them to drink water and the hyponatremia will get corrected. And how to calculate how much free water deficit, how much extra fluid we will tell them to drink is we calculate the free water deficit. Again, it's very easy to calculate. Free water deficit is calculated as the total body water. We calculate the total body water, which is calculated with by the body weight with the patient factor. Patient factor depends on the male, female, and the age of the patients with the factor that we have given. And we design a target sodium and we what is our current sodium, and then we calculate the free water deficit. That is the formula. We calculate the free water deficit like somebody with a 60 kg male, sodium is 150, who is thirsty, then we calculate the free water deficit as 2.7 liter, and then we allow them to drink 2.7 liter of water extra over the next 24 hours, not instantly, over the next 24 hours. We correct over next 24 hours. And suppose somebody who is having ongoing loss, then we just add like 2.7 liter. Suppose somebody who is having 1 liter of extra loss, we just add extra liter to the, which is contributing to the loss, and we correct them over next 24 hours. And always we check after 12 hours how much correction we are at, whether the correction is becoming adequate or not. So we'll continue our case vignette. So that 58-year-old woman. So again, so this is not a mild hypernatremia. This is a kind of moderate hypernatremia, and the patient is obtunded and she cannot drink. So what will we give? We try to give free water. We can try and give free water through the either RT, but again the patient is having ileus, so we will not be able to correct the free water through oral route or nasogastric route. So we'll have to give free water through IV. And you aim to give 0.5% of sodium chloride solution, and your aim is to increase the sodium concentration by 5 millimole over next 12 hours, like 10 millimole over next 24 hours. That means the 5 millimole over next 12 hours. Now, again, questions are asked. Often the questions are asked in the practical exam. How much sodium you should theoretically fall with 1 liter of 0.45% of saline. Again, everybody in the exam. So if you are asked that okay, you will give 0.45% of saline, then the next question is that how much saline you will give. So that means you should know that how much saline, how much half strength saline can decrease the sodium by what amount. So that you should know. So for that again we know this Media's formula that we normally do. Again, most of the time we should practically use this formula day-to-day basis, so that you should know that how much of 1 liter of any infusion of that can lead to follow-up of how much with what magnitude. So again, we calculate with this formula, then we see that again total body water. Suppose in the same patient, the patient is 63 kg and we give 0.45% of saline. So how much total body water is 0.5 of 63 because of this elderly female. So 0.545% of saline contents of 77. So 1 liter of half strength saline will decrease the sodium by 2.5 millimole per liter. So you give 1 liter of 0.45% of saline, so that will decrease the sodium by 2.5 millimole. So that means that if you need to decrease the sodium, your target range is you decided that you need to decrease the sodium by 5 millimole over the next 12 hours. So what you do that to decrease the sodium by 5 millimole, you need to give 2 liter of 0.45% of saline over the next 12 hours. And suppose the patient is having ongoing NG loss of another 1 liter over the next 12 hours, that means you need to add that amount of fluid as well into the calculation. So suppose if she is losing another 1 liter in the next 12 hours, so you add 3 liter of 0.45% of saline over the next 12 hours. So at what rate you will give? I will give at a rate of you will 250 ml per hour. So it's very common calculations, but again, you need to do every day in the ICU whenever you share patients. You just calculate it like this, and then probably in the exams you will be able to move fluid. So how much again we need to correct? So it depends on the body fluid, what exactly he is losing. Most of the time, the gastric aspirate, they contain the sodium of around 70, 75. So it you tend to replace with a half strength normal saline. So that you also need to remember. One important aspect is how do you manage the hypernatremia with a volume balloon. Suppose you have given a lot of bicarb, or suppose a patient is attended in the ICU who is clinically now bloated, and then positive balance of 15, 20 liter of 20 liter, and the patient is hypernatremic. So what normally we do, we start diuresing the patients, then the sodium again goes up, then we end up again giving free water, and then exercise the water. It's again very common situations inside the ICU. How do we do that? How do we treat that? The most important thing is that we should add the thiazide diuretics or amiloride. Why? Because the thyroid diuretic, in addition to the loop diuretics, that promote natriuresis, and that causes preferential sodium loss. So adding a thiazide along with the loop diuretics always helps. Suppose somebody is developing alkalotic, then you just add amiloride to prevent alkalosis. Is there any evidence? Yes, there is a paper is there. So using additions of thiazide diuretics in addition to the furosemide, that increases the natriuresis, improves the creatinine clearance, and then it helps to prevent hypernatremia and the volume overload. So you need to give both the thiazide and the furosemide together. Coming to the brief discussion on the diabetes insipidus, three major reasons: central diabetes insipidus, nephrogenic diabetes insipidus, and gestational diabetes insipidus. What happens in the diabetes insipidus? Your ADH hormone, their secretion gets decreased. So whenever the ADH is low, then what happens? There's a decreased water absorption. So that means that your urine output will be high. So the patient will be polyuric, and the patient urinary osmolality and the specific gravity will be low. Or it increases the serum osmolality, so patient will be polylepsic. So that is the predominant mechanism where the ADH hormone gets suppressed, or ADH hormone doesn't get secreted inside the body. So that is the reason that the diabetes insipidus happens. One important thing that suppose we are suspecting, we should know that the common scenario where the diabetes insipidus can happen in what are the causes of cranial diabetes insipidus, and what are the common causes of nephrogenic diabetes insipidus. Important to remember that isolated pituitary injury doesn't cause diabetes insipidus. To develop diabetes insipidus, we need to have a pituitary hypothalamic damage. So whenever somebody is doing a pituitary surgery, the surgeon is inadvertently damaging the hypothalamus, they will develop diabetes insipidus. If the hypothalamus is spared, diabetes insipidus doesn't happen. Somebody who has a severe traumatic brain injury, or somebody who has a brain dead, there's a hypothalamic problem is there, then the cranial diabetes insipidus will happen. The nephrogenic diabetes insipidus, usually a lot of reasons are there, and then they might be drug induced. There are secondary causes of nephrogenic diabetes insipidus that we should all know. First is anybody with a hypercalcemia. It is a risk. It causes nephrogenic diabetes insipidus. Hypokalemia causes nephrogenic diabetes insipidus, and let's make the patient produce a lot of dilute urine. So it causes the nephrogenic diabetes insipidus. At least these two causes everybody should remember, because it has a day-to-day practical implication. How do we diagnose the diabetes insipidus, or how do we differentiate the different causes of diabetes insipidus? Again, we should suspect diabetes insipidus in patients with the polyuria. So how do we approach patients with the polyuria? First of all, we rule out the common causes, like somebody who has been given the diuretic, somebody who has a cerebral salt wasting, somebody who are hypercalcemic, hypokalemic, or somebody who hyperglycemic. Usually they are polyuria. You exclude those causes, and then you see that whether the polyuria is because of the diabetes insipidus or not. So usually in the diabetes insipidus, what happens? In diabetes insipidus, firstly we see the plasma osmolarity. If the plasma osmolarity is high, then it favors the diabetes insipidus. If the plasma osmolarity is low, usually the polyuria is because of the primary polydipsia. The diabetes insipidus is usually confirmed, but with the water deprivation test, usually it is not a common test to be done in the ICU, but mostly the urine osmolality is high, then it favors the diabetes insipidus in ICU. How do you differentiate between the central and the nephrogenic diabetes insipidus is by administration of the DDAVP. If the DDAVP administration of the DDAVP concentrates the urine, then it is a central diabetes insipidus. If it cannot concentrate the urine, then it is a nephrogenic diabetes insipidus. Treatment of diabetes insipidus, most importantly, free water replacement and correction of the underlying cause. In case of central diabetes insipidus, we can use desmopressin either intranasally or orally, or somebody who is who is hemodynamically unstable, we can give vasopressins as well. The nephrogenic diabetes insipidus is treated either with thiazides or amiloride because, again, as I've told you, because it stimulates the water reabsorption in the proximal tubule, so it corrects the free water excretion. So that is how we treat the hyponatremia. So before we go to the hyponatremia, has anybody any questions? Just let me check the. Okay. See if there are any questions. Is there any questions on the hypernatremia? If there is no question, then we will just proceed.
Yes, can I ask question?
Yes. Please.
Yes, the main problem in case of postoperative neurosurgery patient came to the ICU for postoperative ICU, then sometimes it's very difficult when there is also chest trauma with acute LVF patient. So, in case of targeting, in case of Paul Merino, I am referring this all from the Paul Merino. Suppose the serum sodium is 160, the target serum sodium is 140. That means the difference is 20 millimole. We cannot correct zero point 0.5 millimole per hour. We need 40 hours. If we give baby saline, that means half strength of normal saline, it will take 8.1 liter. So 40 hours, 8.1 liter, that means 200 ml per hour. And if we correct with the normal saline, it will take 4.1 liter to correct serum sodium from 162 to 140 for the next 40 hours.
Okay.
So, is there any problem? The main problem we face in our ICU, if the hypernatremia comes with the overload with postoperative neurosurgery after accident.
So again, I don't think I think there is a kind of problem in the calculation of the corrections. Suppose somebody's sodium is 160, and then you give us you are using a normal saline. You just put them in the formula. J, how much? Sorry, just close this. How much normal saline you will require, because if you give normal saline for this kind of patients, your sodium will not get corrected by more than 0.2 millimole per liter even. So you will end up giving a lot of normal saline. You will require a lot of normal saline to bring down the sodium from 160 to 140, because what is the concentration of the sodium in the normal saline? It is around 154. So then
Yes,
how do
154.
how will you expect the sodium to go down to 140 with the administration of the saline, with normal saline? It will not. It will never go down to 140 because patient sodium is 160. You are giving a solutions with a normal saline, with a saline where sodium concentration is 154. Then how will the sodium will go down to 140? It will never go. You will never be able to achieve your target sodium concentration to 140. It will never happen. So if you need to decrease the sodium concentration to 140, then you will have to have a solution which contains sodium less than 140. The commonest that we use is the half strength saline, which contains a sodium of 77. So you keep on giving half strength saline, and then only your sodium concentration will go down to will come down. You can use 5% dextrose as well. Suppose you want to correct a little faster, then you can use 5% dextrose. But for most of the patients with the half strength normal saline, use of half strength saline is appropriate. Why? Because it allows you to gradually correct the sodium. Sodium will not precipitously fall within few hours. You have a more controlled correction, and most importantly, that you just calculate that the how much saline you will require over the and how much hours. Suppose you want to correct 10, like that means that the patient sodium is 160. Over the next 24 hours, you need to bring down the sodium to 150 only. You don't want to bring down the sodium to 140 over the next 24 hours.
Yes.
You have to.
So the 4 liter baby saline we need, isn't it?
So you can use baby saline. Baby saline contains
So my
0.2%.
problem is that if the patient comes with acute LVF, we cannot give the 4 liter of the baby saline. Then what step, what measure we can use when the patient comes with this complex situation? Then what will be my target fluid
So whenever
correction?
the patient is in a LV failure, your problem again is
Yes.
you need to treat the LV failure first.
Yes. Oh, so we have
Why?
to treat the LV failure first. Okay. Okay. Okay.
And why do you think that somebody who has an LV failure has gone into hypernatremia? So the patient is in a so that means that something must have done a lot terribly wrong. The patient is in LV failure. We must have given a lot of saline, or we must have given a lot of bicarb to correct the acidosis, and that is why the patient has gone. So you have to give diuretics to him. What diuretics you will give? You just add the both thiazides and the loop diuretics so that you have a preferential sodium loss.
Okay.
So,
Thank you.
so that is why I have discussed this situation with the hypervolemic hypernatremia. So if you see the hypervolemic hypernatremia, so you need to have a drug which causes preferential sodium loss,
Thank you,
and
sir.
either diuretics is the preferred choice for that thing.
Thank you, sir. Thank you, sir. Most welcome.
Okay. So anybody else with any other questions of the hypernatremia? Let's look at how to manage. Sorry, I think we have asked the same questions. The DCM of EF 25%. What about high dose DDVP in nephrogenic diabetes insipidus? Yeah, DDVP. Usually, if we talk about the complete nephrogenic diabetes insipidus, DDVP doesn't have any role. If it is a partial nephrogenic diabetes insipidus, DDVP can work. High dose DDVP may work. Desmopressin in resistant type of hypernatremia. Again, it's a in central diabetes insipidus, desmopressin will work. Thiazide diuretics fine. Induced hypernatremia. What should be the target of? So what do you mean by induced hypernatremia? So that you have to ask. Okay, I think that there is no other question. So we'll proceed to the hyponatremia. Otherwise, we'll not be able to see. Okay. So we'll discuss about hyponatremia. Has anybody questions anything? Sorry. What about dialysis? You can also take. Yeah, of course. Well, suppose dialysis. Suppose the patient is this kind of situation. The patient is volume overloaded, and you're not able to manage at all. You just put him on a dialysis machine, and then you control the sodium with the dialysis machine. You need to control. Suppose somebody's sodium is 140. You need to very slow in the dialysis, because your dialysis sodium content. Suppose if it is 135, then the patient's sodium will suddenly go down to 135, and the patients will develop brain injury. So you need to increase the sodium content in the dialysis. So that is the only thing that you need to remember. Uh, Initiating dialysis for correction of the hypernatremia, or you can do a CRRT, which does very slow correction of the hypernatremia. That you can very well do. Suppose your medicine fails, then you can put them on the dialysis. Anyway, okay. So we'll talk about hyponatremia. Again, hyponatremia is exactly opposite to hypernatremia. That means that the hypernatremia is relative deficiency of free water inside the body. Hyponatremia means that it is a relative excess of free water to the solute. We'll do a MCQ, and I need everybody to answer the questions, and then we'll proceed. A 74-year old man admitted with the emergency department with an acute confusional state. He is clinically euvolemic. Very good. There's an X-ray with a suspicious looking mass. His serum sodium is 105. Serum osmolality is 230. SIADH is suspected. Good. We have given the diagnosis. Which of the following biochemical finding in this patient would best support the diagnosis of SIADH? Okay, I want to give answer. What is the correct answer? Again, it's an edic question, so I hope few of you will be appearing for the edic as well. And again, it's a kind of very clinical kind of questions that you can see. We see a urine sodium for and urine osmolality, urine sodium for diagnosis of hyponatremia. Let me see whether any C, D, A. I'm getting a lot of different types of different answers. B. Only E is paired now. B. So that means I can somehow add to the knowledge. E is no, nobody has marked E. Oh, yes, somebody marked E. Yeah. Okay. So that means that we need to clear. We're seeing a kind of various types of answers over here. Over here, that means that probably I will try to make up clear the concept so that this kind of questions are never answered wrong in the exam, because this is the kind of very basic things that everybody will expect you to understand and know in DNB exam. The answers over here is B. So everybody can just mute, please. Yeah, thank you. So answer is over B. Why? We'll just proceed. If somebody is still not clear after my session, then he can ask me. What happens in the hyponatremia? Again, there's again famous uh, mm, image from the NEGM article on hyponatremia. Everybody should read this article. So what happens exactly opposite to the hyponatremia? What happens in the hyponatremia? There is a water gain inside in the brain tissues. So brain tissue swells. It causes some cerebral edema kind of things. So when the brain tries to adapt, then it makes a lot of low osmolar solutes to enter inside the cells so that it can maintain the cellular tonicity and the osmolality. So that is how the brain tissue swells. Now, that is how the brain tissue adapts. Whenever there is a improper corrections, like rapid correction, what happens? The brain tissue is already tries to adjust. Then you give a hypertonic saline and then makes the brain tissue shrink, then it causes osmotic demyelination kind of change. So it's a rapid adaptation of the brain tissue that is responsible for the demyelination in patients. And when you correct gradually, then the brain goes back to a baseline state. That is why the rapid correction is not right. Now, how do we evaluate hyponatremia? Again, this is a very famous textbook kind of presentations. The where everybody will say that okay, so this is the everybody knows about this table, but the main problem why most of the time we do not follow this kind of tabular things, because the major problem in this entire algorithm is that estimation of the volume status, and we are very poor to assess the volume status in the ICU, to be very frank, and it is very subjective. So the basic crux in the entire chart to maintain the volume status and then differentiate what is the cause of hypernatremia, so that cannot happen, so we miss. So that is why the way I do it, I will just try and tell you how do I approach anybody who develops hyponatremia in ICU. First, we just need to identify whether the patient is truly hyponatremic or whether the patient is in a pseudo hyponatremic. What is true hyponatremia? When the hyponatremia is associated with the less serum osmolality is less than 275 or 280, that means it is a true hypotonic hyponatremia, that is a true hyponatremia. Whenever the serum osmolality is more than 275, that means it is non-hypotonic hyponatremia, that means it is not true hyponatremia. First, we try and differentiate between the true hyponatremia and non-true hyponatremia. That is the first thing. So that is why we check the serum osmolality first. So in case of non-hypotonic hyponatremia, we need to understand what is the cause of non like serum. The serum sodium is less than 120, 135, but the patient's serum osmolality is more than 125. That means the patient is not hypotonic, hypoosmolar. So then the entire so we don't need to go to any algorithm. So it either happens either because of this isotonic hyponatremia or it's a hypertonic hyponatremia. So two different things. Uh, the it's a translocation hyponatremia. Usually that happens because of this severe hyperglycemia, or if you give a mannitol, or hypertonic contrast dye, or we use the irrigation fluids. So in those patients, the glycine fluid in the irrigation fluid, so then it patient develop hyponatremia where the patient's osmolality is normal. So we just need to correct what is the corrected sodium. Like suppose the patient's having a blood sugar of 200, then and the patient's sodium is 132. It might not be a true hyponatremia. We just do a corrected sodium and then check that with this formula, and then the serum sodium will be normal. So we don't need to correct the sodium. We don't need our energy to. We don't need to direct our energy to correct the sodium. We just need to correct the underlying pathology, like correct the hyperglycemia, all those things. What is a pseudo hyponatremia? When the serum osmolality is higher, that means the patient is having a higher osmolarity agents inside the body, and the patient's sodium is spuriously low. Again, what we need to do, it happens whenever the cholesterol or triglyceride level is elevated or protein level is elevated. So we have again corrected formula over here. We just put in a formula and we check the corrected sodium. The corrected sodium is normal. We don't need to see that whether the sodium, we need to direct our energy to correct the
এই
sodium.
পেশেন্ট রেডি করে আমার বলেন শোনো আচ্ছা আর একটা
Sushmita, please keep the audience mute.
Sure. Thank you. So there is a kind of, you can also get a various algorithm regarding the glucose. Again, I'm not going into details. Now, coming to the true hyponatremia, or what is the hypotonic hyponatremia? What is hypotonic hyponatremia? That means your sodium is low, serum sodium is low, and your serum osmolality is also less than 275. That means it's a hypotonic hyponatremia. Then what do first do? In comparison to the previous algorithm, so we do not go by this algorithm. What we do, we just check the serum urine osmolality first. Which if the urine osmolality is less than 100, that means that the patient is hyponatremic, but patient's kidney is fine, that it is able to dilute urine. That means what we do, that means the patient is drinking probably extra water, and that is why the patient sodium is going down. It can happen with the primary polydipsia, with patients who have hypotonemia, somebody who is taking a lot of low solutes. So those patients, so then again, the algorithm completely changes. So we just need to correct that part. Okay, we just need to restrict water. The patient's sodium will automatically go up. If the patient's urine osmolality is more than 100, so that means that even despite having a hyponatremia, patient is having a presence of ADH activity inside the body. That is why I have told in the beginning, any sodium problem inside the body is a problem in the ADH, proper or improper. So we check the urine osmolarity, and if the urine osmolarity is more than 100, that means the patient is having a persistent ADH activity. Then we need to find the why the ADH activity is persistent despite the serum sodium is low. To understand that thing, we check the serum sodium, urine sodium, not serum sodium, urine sodium. If the urine sodium is less than 20, then urine sodium is low, always a signal that our body's RAS is activated because of this hypovolemia or because of this some other reasons. If the RAS is active, if the urine sodium is less than 100 and the patient is hypovolemic or dehydrated, that means the patient is having some external loss, and that is why or patient is not taking food, and or patient is probably is dehydrated. So that is why the patient is hypovolemic. Or if the patient is hypervolemic, then you can see that the probably is because of this heart failure, or patient is nephrotic syndrome, or patient is the cirrhosis with the portal hypertension, that can give to, or hepatorenal syndrome. So that can lead to low sodium. Suppose the urine sodium is elevated and the patient is clinically hypervolemic, then probably it's because of this kidney failure. So that is why the patient's sodium is low. But if the patient is not clinically hypervolemic, then probably either patient is euvolemic or hypovolemic. It's very difficult to understand whether patient is euvolemic or hypovolemic. So what we do, so then they have a DD. Either the patient is receiving diuretics, or patient is having a cerebral salt wasting, patient is having a ACTH deficiency, or hypothyroidism, or SIDH. Classically, SIDH is euvolemic, and classically, apart from SIDH, all our other entities are classically hypovolemic. But if you just go by this chart, what we normally do with the patients, with whoever comes to the hyponatremia, we just check the urine osmolarity. We assume there is a 2 hyponatremia. We check the urine osmolarity. Most of the time, urine osmolarity, all this history we just get to know from the patient's history. Patient is taking some psychiatric illness, taking a lot of water, hyponatremic. Probably it's a primary polydipsia. And we straight away go to the urine osmolarity and we check the urine sodium. We check the urine sodium. Urine sodium is less. That means that the patient is hypovolemic, or patient is having a RAS is maladaptively activated because of this cirrhosis or heart failure or nephrotic syndrome, or the patient is urine sodium is more than 20. That means either patient is having renal failure or patient is having SIDH or all other. So that is a very simple way that I usually look into the causes of try and establish the cause of hyponatremia. That is why. But we can just go through a very simple algorithm. We just know to, and we can just clinically apply it on a day-to-day basis. Okay, now we have determined how to determine the etiology of the hyponatremia. That we have discussed the algorithm part. But before going into the algorithm, first of all, we take a proper history, because most of the time history gives an idea of what is the cause of hyponatremia. Anybody who is a long-standing thiazide diuretics comes in a elderly patient on long-standing thiazide diuretics comes with a hyponatremia. That means it's a drug-induced, diuretic-induced hyponatremia. So we just cut off the thiazide diuretics and then let the sodium will automatically go up. Patients with a history of diarrhea, poor oral intake, so usually it's a cause of dehydration. So we just that is the cause of hyponatremia. And we try and find out whether it's a chronic hyponatremia and an acute hyponatremia with our history. And we also try and assess the severity of hyponatremia from our history. We try and assess the volume status and the cardiac function by seeing the edema, weight change, evidence of dehydration, or we do a bedside echo to see the volume status. And we do our labs, serum osmolarity, urine sodium, and urine electrolytes, and the serum other electrolytes. So that is how that are normal things that we should always do, anybody who encounters hyponatremia. And again, in the practical exams, everybody will be asked this kind of question. Suppose your patient got on hyponatremia in a short case, then you will be asked how will you assess how will you determine the etiology, in what fashion, and what do you do. You just need to tell all these things. Signs and symptoms, again, I'm not going into details of this table because everybody knows about it. We classify mild, moderate, severe when determine the acute and chronic. I'm straight going to the treatment of hyponatremia. Treatment, anybody with the severe symptoms, we need to give 3% saline, 100 to 150 ml. And we need to give 3% saline over 20 to 30 minutes. Everybody need to understand the 3% saline. If we try to give the 3% saline to correct the hyponatremia, first of all, 3% saline needs to be given only when patient is severely symptomatic. Patient is not severely symptomatic, we don't need to use 3% saline. If the patient is severely symptomatic, that means the patient is having convulsions, the patient is already very, very obstructed, you use 3% saline. And we use 3% saline to rapidly correct the sodium by 2 to 5 millimole, so that the sodium goes up acutely, and then the patient's symptoms, you reverse the symptoms. And that is why we don't need to give 3% saline over 4 hours, 10 hours. We need to give 3% saline as a bolus over 20 to 30 minutes. And that is the recommendation as per the European guideline. You give a 3% saline over 20 to 30 minutes, and you check a sodium after 1 to 2 hours. And you keep on giving the bolus till the serum sodium goes up acutely by more than 2 to 4 millimole per liter. Or the patient symptoms subside. So patient symptoms improve. Patient symptoms improve, or you get a target sodium rise by 3 to 4 millimole. You stop 3% saline, and then you try and assess what is the what is the diagnosis, what is the cause of hyponatremia, and you start your diagnosis specific treatment. 3% saline is only to correct the severity of the symptoms. As soon as the symptom is corrected, you stop 3% saline. Anybody who doesn't have any severe symptoms, first we try and find the cause of hyponatremia, and we give diagnosis specific symptoms, and we check the periodic sodium. 3% saline is not indicated. And whenever we correct the sodium, everybody knows that we limit the sodium correction by not more than 10 to 12 millimole per day in first 24 hours, and beyond that we additional at 8 to 10 millimole per next 24 hours. So that is the aim of corrections. Now everybody is very scared of giving 3% saline as a bolus. So now we need to understand that how much sodium can actually happen with 100 ml of 3% saline. So we usually have 100 ml of 3% saline. So how much sodium can actually theoretically rise with 100 ml of 3% saline? That you should know, and that is your fear will go out. Again, we put them in a formula. Again, this famous Media's formula that we put. So let's assume a 60 kg of male patient, symptomatic, serum sodium is 110, and he's symptomatic, and you want to administer 3% sodium saline 100 ml. How much saline, 3% saline of 100 ml can actually rise if you given a bolus? Just put in the formula. You see, if you give 1 liter of 3% saline, your sodium will change by 10 millimole per liter. So you give 100 ml of 3% saline, whatever way you give, you will not be able to increase the sodium by 1 millimole per liter. So 1 millimole per bottle. So your serum sodium concentration will not rise by more than 1 millimole if you give 100 ml of 3% saline. So there is no point of giving a 3% saline over 10 hours, because our aim is not to correct the 3% saline over increase the serum sodium concentration by 1 millimole over 10 hours. Our job is to correct the sodium concentration by at least 2-3 millimole per rapidly, so that the symptom subsides. So that is why sometimes we give a 100 ml bolus, and then we just check it, sodium rises, and then our symptom doesn't subside, then we give one more bolus, and then the symptom subsides, the 3% roll of 3% saline goes out. So again, the idea of having this calculation, showing this calculation to you is that the 3% saline, giving a 3% saline cannot in any way will not increase the your sodium concentration by more than 1 mole. So you can give a 3% saline without any fear, and just try and improve try and correct the sodium by 2-3 millimole over next 1-2 hours, and then stop 3% saline. Important is to stop 3% saline. Now, one of the major limitations of the predictive equations that we really like, calculation of the free water calculations and then calculation of these kind of things, is that we just ignore that the kidney is not functioning. That means the kidney is not excreting water at all. So this kind of predictive equations ideally help in somebody who is an acute renal failure, who is anuric, the kidney is not functioning at all, or we have given a DDABB clamp. I hope everybody has heard the term of the DDABB clamp, and then we prevent the urine to excrete urine. Then only these predictive equations help. But problem happens that as soon as we start correcting the etiology, kidney automatically starts correcting the sodium on its own. So whenever the kidney starts correcting on its own, then the sodium also starts correcting on the. So that is why it is very important to monitor the urine output in these kind of patients. Suppose that you have started correction, suppose the patient is in hyponatremia, but you have given some 3% saline, or you have not given 3% saline, we have just started to correct the offending things, and your patient has become polyuric, then the kidney is functioning a lot, the kidney is producing a lot of free water. That means the sodium is getting auto-corrected on. So in those patients, you don't need a 3% saline, you don't need any other medicines to correct the sodium. The body is trying to correct on its own. So we should know the predictive equations, but whenever the kidney is functioning, most of the time it doesn't work. So most of the time we feel that okay, we have put the patient on a formula, but the patient is not behaving as a formula, because your kidney is also trying. You are also trying to correct the sodium. The kidney is also trying to correct the sodium. And that is why probably your equations are not working well. So that is why most of the time this predictive equation fail. But if you want to make your predictive equations work, what you need to do? You need to put a DDAVP clamp, and that is what we usually do. If you give a very good answers in a theory or in a practical, they will ask you the DDAVP, what is the DDAVP clamp technique. Everybody should know about it. Most of the we do not practice it very often, but we should know when we should use this kind of technique. What is the principle of using a DDAVP clamp? You just give a lot of ADH and then you prevent the kidney to secrete a lot of free water. So that means the body acts as a container, and it will act as it will act as a more predictable way. So you administer hypertonic fluid, your sodium will increase. You give a hypotonic fluid, your sodium will decrease. So you can change the body sodium as per the predictive equations. So that is how it helps. So suppose somebody comes in hyponatremia, you need to correct the sodium the way you want. What do you need to do? You will just put them on a DDAVP clamp technique. You just block the kidneys water excretion with the DDAVP, high dose of DDAVP, tell the kidney not to produce a lot of urine. And you start giving, suppose the patient is hyponatremic, you will start giving hypertonic saline, and then it will behave exactly as a predictive equation, and your sodium will become extremely accurate way. The way you want, the sodium will increase. Suppose you want to decrease the patient's sodium, you again put a DDAVP clamp, and then you start giving hypotonic saline, your sodium will exactly follow your equation. When do we use this DDAVP clamp in practical scenario? Suppose somebody in osmotic demyelination, anybody with a very severe hyponatremia, somebody with a coexistent hypokalemia, somebody with a cirrhotic, most of the time it is on textbook indications to use DDAVP clamp. So most of the time, there are again classical indications. Most of the time, we do not preemptively use DDAVP clamp technique. We end up using DDAVP clamp technique whenever there is some autocorrection is already happening and the sodium is rapidly rising. Then you just use the DDAVP clamp and then take the kidney into your command, and then you start correcting the sodium as you like. So that is the more practical. That is the commonest way that we use over here. How do we perform? We give a high dose of DDAVP, and along with DDAVP, it is important to restrict free water. Why it is important? Because what DDAVP does, it prevents the kidney to excrete free water. That means your free water is inside your body. If you do not restrict your free water, then your sodium will precipitously fall. So both are important. You just give a high dose of DDAVP and then restrict free water, and that is how the DDAVP performs. And then you use your 3% saline or bicarbonate as per your choice, and then your sodium will go up adequately. Suppose at any point of time sodium goes back to a normal, you just stop DDAVP, and then after 10 to 12 hours you just liberalize intake whatever the patient wants, and the action of the DDAVP goes out, and then sodium will go back to the kidney's physiology. So that is how we perform. Now, again, Vaptans are very commonly used, but again, everybody should know the problems associated with Vaptans. We should know that the European guideline for the hyponatremia do not recommend Vaptan for a regular use. In selected cases, they are recommended to use, otherwise they are not used. Why? Because the water loss that happens with the Vaptans, they are very unpredictable and uncontrolled. You do not have any control on the rise in sodium. So it can develop overshoot hypernatremia. It can lead to risk of osmotic demyelination, and they are potentially hepatotoxic. So they're usually you should use the Vaptans in a very cautious way. Important clinical entity that you should all know, that the hyponatremia with a coexistent hypokalemia, how to treat, because I have told that the hypokalemia induces a state of nephrogenic diabetes insipidus. That means that anybody who has an hypokalemia, they cause a lot of free water excretion from the body. So whenever we give potassium supplementation in this kind of patients, so they actually end up rising sodium inside the patient's body. So it has been seen that if 40 kg patients with the oral dose of 40 mg potassium, they actually increase the serum sodium by 2 mg per liter. So most of the time, Oral replacement of potassium usually increases the sodium, per se increases the potassium. So anybody who has a coexistent hypokalemia, they are a very high risk of developing osmotic demyelination because the rapid correction of the sodium. We should be careful about that entity. We should know about this entity. Anybody hyponatremia, hypokalemia, we should be very careful in correcting the sodium because sodium will precipitately will increase with even small dose of normal saline, 100-200 of normal saline, patient will start producing a lot of urine. Hyponatremia with a congestive cardiac failure, again, it's a challenge to you, challenge to manage. But again, as I have told previously, the focus is always to treat the heart failure because congestive cardiac failure patients developing hyponatremia, it's a risk factor for mortality. Why? Because the hyponatremia is a reflection of the poor systemic perfusion in these kind of patients because your RAS is maladaptively activated. So that indicates the severity of the heart failure. So your aim is to treat the heart failure. Usually, the loop diuretics are quite safe because it causes preferential water loss than the sodium loss. In oral urea, we usually do not get in India, but Western countries oral urea is available. We can use Vaptans with cautions, but again, we should know that we should be giving Vaptans in a very low dose and then titrate the dose. The concept of hyperdiuresis is there, where suppose somebody is symptomatic hyponatremic and then also hyponatremic and also heart failure, then we just give a 3% saline and we give a high dose of IV furosemide to induce a lot of free water loss and treat the hyponatremia and the heart failure both together. And sometimes the SGLT2 inhibitors are used. Coming to the SIDH, again, I'm not going into details of the essential and the supplemental criteria. Everybody knows about this. Everybody should know about the causes of SIDH. 30% of cases it is idiopathic. We should know the differentiation between the SIDH and the cerebral salt wasting. Again, it's a everybody should know the difference between the cerebral salt wasting and SIADH because it is practically important. It's day to day important. The table is there. Everybody should know. The most important differentiating factor is in SIADH. Usually the urine output is normal, and somebody with a cerebral salt wasting usually they are polyuric. So that is a very clinical important way to differentiating between the SIADH and the cerebral salt wasting. Just highlight the treatment of SIDH. Somebody who is acute, very symptomatic, just use 3% saline and increase sodium rapidly by 2 to 4 millimole per liter. Suppose who is not that much very symptomatic, then we just try and identify what are the causes of SIDH and try and address those things. Increase the protein and salt intake for the patients. Restrict the fluid to less than 1 liter per day. But usually what happens if the urine if your urine osmolality is more than 130, 140, then most of the time this fluid restriction fails, so it doesn't help. So oral urea is a good way to treat the SIDH, but again, we do not get it in India. So sometimes we give Vaptans. If the fluid restriction fails, we just give Vaptans to treat the SIDH over here. Just last slide, what are the clinical parts in the management of the hyponatremia? Sudden increase in urine output more than 100 ml per liter. Anybody who is hyponatremic, it signals the increased risk of rapid rise in serum sodium concentration. So we should be very careful in those patients. So it is very important to monitor urine output whenever we are trying to correct the serum sodium in any patients with hyponatremia. And it happens whenever, especially somebody who is hypovolemic or somebody hypokalemic, that happens. And suppose we have suddenly done overcorrections within 12 hours, suppose the serum sodium goes up more than 10 millimole, then what do we do? So re-lowering of the serum concentration, sodium concentrations do help. So what we do need to do is just discontinue the ongoing active treatment and we start a treatment of electrolyte-free water or glucose solutions or hypotonic solutions to rapidly correct the serum sodium. That helps and that prevents the osmotic demyelination. And in this kind of patient, suppose the rapid lock is there, then we give a desmopressin lock that we have discussed. So that's all.
Thank you, sir. Any aspirants, if you have any question, you may ask now.
Hi, Sudeep. It was wonderful insights on the topic hyponatremia. You've really done a great justice to this topic. Lots and lots of insights.
Thank you.
Basically,
Thank you so much, sir.
yeah,
I didn't see
yeah,
you there.
yeah. I'm
Anything
there.
from your,
I'm there.
anything from your side, what I missed, sir?
I was listening to your topic. very minutely and such a wonderful insights. Even the textbooks also will fail to provide the information that you have provided here.
Mm.
Really, I also learned a lot of things. In spite of reading so much, it feels like there is still a lot to learn about hyponatremia. It's a
Yeah,
very vast topic. Yeah,
yeah, thank you so much, sir. But just try to cover the more practical things that we see on a day-to-day basis. So
yeah.
not on
And
theoretical
these
things
are
that
very
are
important aspects. So one thing, Edrog's Media's formula, and there's so many formulas are available. You need to calculate free water or something like that.
Mm.
So, but it becomes really cumbersome at times, and residents also feel like calculating equations and calculating the sodium loss is becomes it becomes very tedious job. Do you
True.
have any simplest form of correction of hyponatremia? Suppose, I mean, you give boluses of 100 milliequivalent, 100 ml of 3% saline or something like that. But there is a rough formula where if you correct if you want to correct the sodium by 1 milliequivalent per hour or so, you have to give 3% saline at the rate of patient's weight. If patient's weight is 50 kilos, if you continue 3% saline at 50 ml per hour, it is likely possible that you may be able to correct sodium by 1 milliequivalent per hour. Okay. And if you want to correct the sodium by zero point 0.5 milliequivalent, you just give it half the way patient's weight. Okay, these are certain assumptions we follow at times. And we always feel that we should all correct the sodium, initially rapidly, especially when the patient has seizure or patient is drowsy, patient has signs of raised ICP or something like that, where you need to correct rapidly. But there is still a lot to understand how rapidly we should correct. How much should be the volume of 3% saline? It's very easy to say. I mean, we can give 100 ml or 200 ml, but that volume calculation of 3% saline is still misnomer. It's very difficult. Do you want to add or simplify? If my patient's sodium is around 105, so would you like to simplify, the volume calculations and the rapidity with which it can be corrected? You want to throw some
So,
light on this? Yes, we do.
so again, Malab, as I had said, first of all, 3% sodium only use when somebody is severely symptomatic. Do not
Yeah.
use a 3% saline, even though somebody who is 105 sodium patient is not symptomatic. You don't need to use 3% saline at all, because maybe the patient is on a long-standing chronic hyponatremia for a long-standing. You just correct the underlying cause, and then the sodium will gradually rise. So sodium 3% sodium as per the guideline is needs to be used only when somebody is severely symptomatic, not without this indication 3% saline should not be used. And usually on a rough basis, the usually 100 ml of 3% saline in a 50-60 kg of patients usually makes the sodium rise by 1.5, not more than that. So that is why whenever we just need to correct the sodium by 2-3 millimole, you just probably need to give 100 ml of 200 or 200 ml of 3% saline over the next over 1 hour or 2 hours, and then as a bolus we just need to give and just rapidly correct the symptoms, and then we gradually make the sodium rise in its own way after correcting the precipitating cause. So that is the important thing. One question has been asked in the chat box that whether 3% saline can be given by through the peripheral line. Yes, of course, it can be given through the peripheral line. There are enough data and even enough trial has been published now where 3% saline can be safely given to the peripheral line. Only thing, because it's an hypertonic saline, it needs to be we need to be very careful about the thromboseverity. So we need to be careful about your peripheral lines. But it can be given at the peripheral line. You don't need to put a central line for 3% saline all the time.
Yeah, but the preferred will be it will be preferred to use wide bore angiocath,
Yes.
preferably 16 gauge or 14 gauge or something like that. Don't give it through  24 gauge or even 20 gauge cannula also. It's a cause thrombophlebitis and it may be
Yes.
little
Just
bit.
need to be careful about the IV line. If the IV line is fine and well patent and you are using 3% saline as just bolus, you need to be careful about flushing the line properly after your bolus dose of 3% saline goes, and then it should not cause any problem.
Yes, 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 yes. So I think there are a few more questions in the chat box, Sudhir, if we can take these questions. Is it corrected sodium or serum sodium to calculate osmolality in diabetic ketoacidosis?
So again, uh, first of all, most of the time we do not measure serum osmolality in patients with a DKA. If you're using if you need to measure the osmolality, you need to measure the osmolality in a way so that it gives a measured value. If you need to derive the measured serum osmolality, then you need to put it in the formula. But otherwise, uh, it doesn't make it. I don't know whether I do you use. I don't know when was the last time I checked the serum osmolality in the patients with the DKA. It
Yeah.
doesn't matter. So most of the time we just try and correct, focus on the iron gap and the correct the sodium. We tend to see the serum sodium because that is important in correction of the decay, because we tend to give normal saline most of the time. We give a normal saline or we give a balanced salt solution. And even if the patient's sodium is 140 in a patient with a decay with a serum's blood sugar of around 600, that means his corrected sodium is probably around 150, 155. That, and you are giving a normal saline and balanced salt solution, that means that you are actually causing more hypernatremia in these kind of patients. So that is why it is recommended after 1 or 2 liter of saline, you switch to half strength saline in patients with decay. So it's important to monitor sodium in these kind of patients.
Yeah. So basically, to add to Dr. Suvadeep's uh, answer. So basically, sodium can be calculated either it can be in the measured form or calculated form. So measured sodium is basically how the machine measures. You can also calculate the sodium. So basically, the osmolarity. The osmolarity is directly dependent upon the sodium. It is twice the sodium, and you will get the osmolarity. So basically, the factors like glucose and urea, its contribution in osmolarity is very, very less. So generally, in order to calculate serum osmolarity, it is majorly dependent upon the sodium levels. So you can have rough estimation as to how much is the serum osmolarity. If patient serum sodium is 120, so its serum osmolarity is likely to be 240 or something like that. So you can also calculate. It's not necessary that you depend upon machines only. Even simple value of a sodium can also give you value of serum osmolarity. So there is another question, Dr. Sudhir. In dialysis, one of the delegate participant has seen the patient. Hypernatremia was corrected via changing changing conductivity. I'm not able to understand this question. How patients' hypernatremia is corrected with changing conductivity?
So in dialysis, the way we need to correct the sodium is just need to correct the you need to maintain the sodium in your dialysate. So you can change the dialysate sodium concentration. So you change the dialysate sodium concentration. You put it in the we can actually go up to around 145 of sodium in dialysate sodium. So and then you gradually correct it. If you need a very more gradual correction of sodium, both in hypernatremia and hyponatremia, you can just use a CRRT or CVVH device where you have very gradual correction of sodium over 24-hour period of time.
Yeah. So during dialysis, you can actually keep the values of sodium. What is the desired sodium, and what is the patient's current sodium, and you make sure that the sodium correction is not very rapid. Dialysis definitely helps you to correct sodium, especially when the patient has hypernatremia. Even patient with the hyponatremia, sodium corrections can be done with the dialysis. But you make sure that the sodium correction is not more than 10 to 12 milliequivalents in 24 hours. Sudeep, I mean, I have a question. Tolvaptans have been misused quite, often. And whenever we see a patient of hyponatremia, many clinicians they invariably add tolvaptans twice a day, sometimes once a day. Okay, so I think there should be some guideline pertaining to the usage of tolvaptans. As you said, there is uncontrolled diuresis with tolvaptans, and it is unpredictable how much sodium a particular dose of a tolvaptan will be able to correct. uh, you know, and basically, if you know that patient has SIDH, which is not corrected by even water restriction or something like that, probably Vaptans can be used. Do you want to say something about this also?
So tolvaptan, first of all, suppose somebody tolvaptan is contraindicated and somebody is hypovolemic hyponatremia. It's contraindicated.
Mm,
Should not
yes,
use at all.
that's the dictum. Yes, yes.
Somebody who has a renal failure, it is better not to use because Vaptans works. If the kidney is not functioning, your tolvaptan will not definitely work. So again, strict no. Suppose your kidney function is fine and our patient is hypervolemic, we may use tolvaptan because it will cause preferential water loss to patients. So sometimes it might be helpful. Or somebody who is SIDH, where your fluid restriction fails, then we can use tolvaptan. But again, we need to know that as we do not have any control on on the rise in sodium after giving tolvaptan, we should use in a very low dose. Like we should better to give in a start in a low dose and then see the response. And after each dose, we just change the serum sodium and see that what is the response that is coming, and then only we give the second dose. So it's not a blanket 15 milligram BD and starts, and then the patient goes in a hypernatremia after and rapid correction of the sodium that happens, then it lands up in the osmotic demyelination. So we can give tolvaptan, start at the low dose, check the sodium depending on the response, assess the response, and then give the next dose. That is how it should be used.
Yes, that's wonderful insight. Yes, we can correct the sodium by changing the dialysis setting. There is another question which was asked. Yeah.
Yeah, we can do that.
Yeah. So any other question? Any take home message that you would like to give to the audience, Dr. Sudhir?
Take home message
Anything?
is that everybody should know the sodium, how to manage sodium inside in the ICU.
And the
We
clinical condition of the patient is also very important. We should be able to
uh,
assess the patient clinically. We should
managing
not use.
sodium.
Hmm.
Sorry.
We should not use it just to correct the numbers, but we should see the patient clinically as well,
True, true.
especially the volume status of the patient, whether patient is dehydrated, isovolemic, or hypervolemic. So that factor is also very important. And we end up correcting sodium unnecessarily most of the times, and we end up with the problems. How many patients did you see any patient having pontine myelinosis in your clinical practice, Dr.
First of all,
Sudhir?
again, this is very. First of all, it's not very common to be very frank, but yes, we have attributed one patient to the ODS because of this rapid correction. Especially, it happens in the post-operative setting. Sodium, somebody becomes acutely hyponatremic and then starts correcting the sodium, and then they go in a pontine myelinosis kind of thing. But again, this is not as common as we talk. That is why I have not covered the ODS at all in this discussion because it is not that common. And there are even papers now coming up with these things that the osmotic demyelination is a myth. But
Yeah.
again, I'm not saying that we should be overcorrecting sodium, but it does causes problem to the brain because and it should cause it theoretically it can cause the brain damage. So everybody should be afraid of osmotic demyelination the way we are. But again, it's not very common entity to be very frank.
Yes.
My last question. The patient came with this electrolytemia in the form of hyponatremia, hypokalemia, and hypomagnesemia also sometimes. So in that case, or hypokalemia also, calcemia also, in that case, which I have only received one patient that create a very problem in that setting, which I should correct first, magnesium or the sodium first?
Doctor, that is the thing I tried to highlight in my discussions also. Forget. So again, suppose patient is very symptomatic because of the sodium, having convulsion. Just give a 3% saline, try and correct the sodium. Bring up the sodium by 2 to 4. But again, somebody who is an who is hyponatremia with a hypokalemia, you correct potassium only. You just correct potassium, sodium will automatically go up. You don't try and correct the sodium at all. Even the patient is sodium is 110, just correct this potassium, the patient sodium will go up. And that is the thing I try to emphasize in this kind of discussions. You just need to we that is the thing we never talk about. Like we talk about the most lot of time we see that the hyponatremia along with the hypokalemia. Focus on treating the potassium. You give a oral potassium, it will increase your sodium by 2 to 4 millimole per liter. And suppose you're facing problem of because of this hypomagnesemia contributing the hypokalemia, and then you correct the magnesium. Magnesium doesn't have any role on the sodium correction, but the potassium does have role. And always you need to try and find out like so if you're telling the patient is hyponatremic, hypokalemic, hypocalcemic, hypomagnesic, that means the patient is malnourished. You try and assess that.
Yes. Yeah.
So you
And
just try and correct it first, but do not try and correct the sodium. And that is the thing I tried to emphasize in this discussion that the if somebody is hypokalemic, hyponatremic, just try and correct the potassium. Do not try and correct the sodium at all. The sodium will automatically go.
so I would also like to
Thank
add
you,
on
sir.
this because the sodium related disorders or hyponatremia will present with CNS manifestations. Okay, they may be drowsy, disoriented, seizures, or whatever. Potassium related disorders will present with cardiac issues, cardiac arrhythmias. So in this situation you need to understand what is more important. Your arrhythmia is causing problem or your neurological status is creating problem. So depending upon this, you can prioritize the correction initially. Once suppose your patient has arrhythmias and patient's hemodynamics are also getting compromised, you will prioritize hypokalemia, but at the same time, sodium correction can also be continued simultaneously and correct the arrhythmias. If the patient is seizing continuously and it is due to hyponatremia, you will give more focus on controlling the seizures. You will correct hyponatremia rapidly. So you prioritize according to the clinical symptoms of the patient. And considering hypomagnesemia, unless the hypomagnesemia is corrected, the potassium is not going to be corrected. Okay, it has to be corrected simultaneously. And as Dr. Sudeep has already said, if you have all these electrolyte disturbances or hypo states of these electrolytes, it means the patient is malnourished. You have to correct it gradually. You cannot correct it rapidly because most of the times when the patient is not feeding, eating, drinking, or whatever, malnourished, all these electrolytes are shifted intracellularly. And when you try to correct it rapidly, there is sudden shift of these electrolytes into the intravascular compartment from the tissues, and there will be sudden hypernatremia or hyperkalemia or hypermagnesemia, and so on and so forth. So remember, if you have such a disorder where you have deficiency of several electrolytes, you have to correct it slowly. Even if the patient may be symptomatic, but you have to correct it slowly. Any thoughts from you, Dr. Sudeep?
No. So that is you're absolutely so I go like this.
So I think we have exceeded the time limit. It was very, very informative lecture, Dr. Sudeep. I also learned. I hope the audience would have loved to listen to you and they would like to listen to you time and again and again. We would be really happy to, request you to, take lectures for our students or delegates. Uh, uh,
Anytime, sir.
yeah,
Anytime.
yeah, more often than not just now. But looking forward to see you again, Dr. Sudhir.
Thank you. Thank
Uh,
you.
Thank you, all the participants. We will be able to come back again in the next week. with the new presentation. And hopefully, you can also suggest us few topics if you really want those topics to be covered. We will invite the speakers, and it's really nice to have interactive discussion rather than just monotonous discussion. We are happy to have this two-way communication when we have such presentations. So with this, we will like to conclude the session, and good night, everyone. And good
Thank you,
night,
sir,
Dr.
for
Sudeep.
the invitation to for the speak. It's always a
Uh,
pleasure.
Doctors, thank you everyone. It was really a very informative and interesting session for the aspirants too. So we would
Yeah.
like to see more of you with the topics and everything. You cover everything very nicely. Thank you.